My name's Dr. Kimberly Humphrey. I'm an emergency physician and a public health doctor who currently works for the Health Ministry of South Australia on climate and health policy for the health systems. Last year and into this year, I was a climate change and human health fellow at Harvard as well, and I've been working in this space for a few years. So welcome to our session on health disparities. This is also a lead into a special edition of the Journal of Climate Change and Health that I'm guest editing that will come out in the near future, which is focusing on those who have less, let's say, who have health disparities, who will be disproportionately affected by climate change. I firstly want to acknowledge that climate change does disproportionately affect certain populations. So we know that within societies, those who have poor social determinants of health, those who are from certain ethnic and racial groups, those who have chronic medical conditions, and of course those in the global south will suffer more than those of us who are privileged and live in the global north. So that is really the basis for this session. Before I introduce our speakers, I'd like to acknowledge the Kaurna people, who are the Aboriginal people of the land that I live and work on in South Australia. So they have been custodians of the Australian landscape for 65,000 years. As we stand at the moment, there is a 10-year mortality gap between white Australians and Aboriginal people. Aboriginal people were very significantly affected by colonisation when white people came to Australia 200 years ago. And last week, some of you may be aware of this, and I've talked to some of you about this, we had a referendum in Australia. In Australia, it's compulsory to vote. So if you're over the age of 18, you are required to vote. And we had a question that was put to the Australian public, which was, should Aboriginal people have a voice to Parliament? And what that would have meant was they wouldn't have the ability to make decisions, but they would have a group that the government would be required to consult on for any legislation that went through. So giving them a voice and making sure that all of the things that affect them would be heard. The South Australian public voted 63% no to hearing the voices of Aboriginal people. And to me, this really just underscores why a panel like this is so important, because we still don't listen to those who are disproportionately affected, who have greater health disparities than others. So I'm very excited to be hearing from our wonderful speakers who will be talking about some of these issues. So first of all, I'm going to introduce Melissa Blum from the ICAN School of Medicine at Mount Sinai. Welcome, Melissa.
Thank you. Hi, everyone. Really excited to be here. Today, I'm going to be talking to you about heat and its effects on obstetric complications during pregnancy. So first, to start off, if this will move, maybe. Sorry. I'm sorry, you showed me the button and everything. Okay, now try. Okay, cool. To start off, I think something we can all agree on is that the Earth is getting warmer. Across many climate projections, this is the case. And it's important to think about because, as has been mentioned in several previous talks, heat has health impacts. Exposure to high temperature can cause negative health consequences. And I think it's also important to recognize that not all groups of people are equally vulnerable to these health impacts, either because they're more or less likely to be exposed to heat, or because they have risk factors or protective factors that affect how that exposure manifests in their health. And one population that is particularly at risk is urban populations, people living in cities. This is because of the urban heat island effect, which is where buildings that are made of concrete and metal absorb solar radiation and then re-radiate it into their surroundings. And in combination with low levels of green space, this means that cities are much hotter than neighboring rural areas, especially in the late afternoon and also at night. And in this study, we wanted to really zoom in on a particular subpopulation of people living in cities, which is pregnant people. And our reason for doing this is that pregnant people actually have a physiologic susceptibility to overheating when they're exposed to heat, because they have increased risk factors, including increased fat deposition, decreased surface area to mass ratio, and increased thermogenesis as a result of the fetus and the placenta. And in normal pregnancy, there are actually physiologic adaptations to avoid overheating, such as increased plasma volume, decreased core body temperature, and lower sweating threshold. But it's still the case that pregnant people are more likely to tip over into heat stress when they're exposed to high ambient temperature in their environment. And so this is one reason that we wanted to focus in on this vulnerable group. So the question is, how does heat exposure during pregnancy affect pregnancy outcomes? And there's existing literature on this topic, which shows that it can affect fetal health, So heat exposure during pregnancy is associated with increased risk of preterm birth, low birth weight, and low APGAR score, which is a measure of newborn health. And it's also associated with pregnancy complications for the pregnant person, including increased likelihood of being diagnosed with gestational diabetes, hypertensive disorders, which means gestational hypertension or high blood pressure during pregnancy, and preeclampsia, and increased risk of vaginal infections later in pregnancy. But the jury is still out a little bit on when exactly this heat exposure has to happen in order to produce these negative effects. So some groups have focused on the first trimester as a vulnerable period because this is when implantation of the embryo is happening and you're establishing placental exchange between the fetus and the pregnant person, which is going to set the stage for later development during the pregnancy. And other groups have focused on the third trimester because this is where sort of rapid growth and development is occurring as the pregnancy ends. And there's also some evidence that heat exposure during this time can trigger labor, which can lead to earlier delivery than is optimal and also lower birth weight because you miss that later development. But still more research is needed to firmly establish when are the critical periods for heat exposure during pregnancy. And we wanted to address this question while acknowledging that not every pregnant person is the same, right? So we suspect, and based on some studies, we know that demographic factors and social determinants of health can influence the likelihood that a pregnant person would be exposed to heat and the impact that that exposure could have on their health. And in this study, we considered race, ethnicity, age, education level, marital status, substance use, socioeconomic status, and parity, which is the number of previous pregnancies the person had that lasted at least 24 weeks. So all these factors could potentially influence how this heat exposure manifests. So to answer these questions, we use data from the Stress in Pregnancy study, which is a longitudinal cohort study conducted in New York City that enrolled pregnant people from 2009 to 2014 at two hospitals, Mount Sinai Hospital, which is where I go to medical school, and New York Presbyterian Queens. And on the map on the right, you can see in red all the areas where people live who were recruited for this study. So they got a really good spread of people living in different areas of New York. The cohort is racially, ethnically, and socio-demographically diverse, and the N is 820 parent-child dyads. So using this data, we wanted to explore when during pregnancy does heat exposure have an impact on obstetric complications, and how is that related to social and demographic factors? So we used this approach, which is assuming that heat exposure during a pregnancy would occur during the summer or the warm season, which in New York we listed as June, July, and August. And as our reference group, we took people who became pregnant in September and then delivered their babies in June, assuming that these people would have the lowest heat exposure since a lot of their pregnancy is occurring during the winter. And then we compared to this reference group people who were exposed to heat in the first, second, or third trimester of pregnancy to see how this exposure would be associated with the incidence or prevalence of obstetric complications. And what we found was that early pregnancy is a critical period for warm season exposure in determining pregnancy complications for the pregnant person. So on this graph, you can see that the orange bars represent people who were in their first trimester of pregnancy during the summer. Green is people in the second trimester, and purple is people in the third trimester. And we examined 3 different pregnancy complications: gestational diabetes, gestational hypertension, and preeclampsia. And on the y-axis is the adjusted odds ratio, which represents how likely was this person to have this diagnosis compared to someone in the reference group of the study who had minimal heat exposure. And those odds ratios are adjusted for the age of the pregnant person, race, ethnicity, marital status, education, parity, socioeconomic status, and substance use. So all of those important social factors that we thought could influence the risk. And what we found is that the first trimester is really where we need to focus. So for gestational diabetes, gestational hypertension, and preeclampsia, first trimester summer exposure was associated with increased risk, whereas the second and third trimester did not have a significantly increased risk. We then wanted to explore within the total study population who was most at risk. And so we stratified our cohort based on race and socioeconomic status. And when we stratified by race, we saw that non-white, which is Black, Asian, and Alaska Native or American Indian participants in the cohort had an increased risk of preeclampsia relative to the reference group in the first and the third trimester, which is an interesting finding because it suggests that there may be different mechanisms at play driving risk, since someone in the first trimester is physiologically different from someone in the third trimester. Whereas white participants in this cohort had an increased risk of gestational diabetes after first trimester warm season exposure. And then when we subdivided by socioeconomic status, we found that people of lower socioeconomic status had elevated risk across all the complications that we looked at, whereas those of higher socioeconomic status did not have an elevated risk of gestational hypertension after first trimester warm season exposure. We also looked at fetal complications, including low birth weight and gestational age at delivery. And what we found was that, again, the pregnancies that were exposed to heat during the first trimester had a lower birth weight and a lower gestational age at delivery. And I want to just comment on the decrease in birth weight of 188 grams. This is a clinically significant decrease that's comparable to the decrease seen when the pregnant person is smoking during the pregnancy. And low birth weight can really set the stage for problems later in life. So definitely an important public health problem to address. So the question is, why are these relationships the way they are? How does warm season exposure during the first trimester potentiate pregnancy complications? And there are different ideas about this. One focuses on placental development, which I touched on a little bit earlier. So there's this idea that if you have heat exposure in the first trimester when the placenta is developing, you can disrupt that development such that there is later on going to be placental insufficiency when the fetus is rapidly growing and placing a lot of demand on the placenta to supply nutrients and eliminate wastes. And when that placental insufficiency happens, you can actually have hypoxia in the placenta, which causes release of vasoconstrictive mediators, which can then make the blood pressure very high in the pregnant person. And in that case, then you need to deliver the baby so that you can get the placenta out and deal with the high blood pressure. And so that's one idea about how preeclampsia might be connected to heat exposure during pregnancy. And then another area of interest is heat shock proteins, which is a family of chaperonin proteins responsible for maintaining appropriate protein folding in times of cellular stress and also high temperature. And it's known to be associated with gestational diabetes pathogenesis in the pancreas, but recently it's also been shown that this family of proteins is highly expressed in the placenta, and their levels in the blood can actually predict in the first trimester whether someone is later on in the pregnancy going to develop either gestational diabetes or preeclampsia. So to conclude, we showed that early pregnancy is a vulnerable period for warm season exposure, and that this vulnerability depends on race and socioeconomic status. And I want to comment here that race and socioeconomic status are acting here most likely as proxy variables for many other things that we would want to measure, right? Like lived experience of racism, genetic background, whether you're working outside, which could expose you to heat, whether you have access to air conditioning in your home, or stable housing, or stable food. So these are all things that need to be explored in further studies. And we also need to do biological studies to explore the mechanisms that link heat exposure so that we can hopefully eventually develop therapies in addition to public health interventions to reduce these exposures. So I want to thank my mentors, Dr. Nomura and Dr. Sheffield, and also two wonderful students who I worked with, Donato and Danny. And thank you very much.
Thanks, Jaga. So our next presenter is an online presenter from Australia. So I will introduce Jacky Dawkins, who is a current project officer at the Sachs Institute based in Sydney, Australia. And we will find her. Okay.
Hello, everyone.
Good to go.
Can everyone see my screen?
Yes.
Perfect. Okay, good afternoon. My name is Jacky, and I'll be presenting the policy analysis conducted by myself and Associate Professor Ying Zhang on integrating health in ecosystem-based adaptation across the Pacific Islands region. Before I start, I'd like to acknowledge the Gadigal people of the Eora Nation, from whose land I'm joining you today. I'd like to pay my respects to their elders, past and present, and acknowledge their continuing connection to the lands and waters, and that sovereignty was never ceded. So climate change is one of the largest challenges in the Pacific Islands region that threatens local ecosystems, infrastructure, food production, and human health. Consequently, various countries regionally are investing in nature-based solutions, such as ecosystem-based adaptation, to strengthen their adaptive capacity. EBA is an innovative climate change adaptation measure that works with nature to build social and economic resilience to the direct and indirect effects of climate change. Importantly, it focuses on the conservation, sustainable management, and restoration of ecosystems to enhance human well-being, resilience, and adaptive capacity of local communities through participatory, flexible, and cost-effective solutions. The Pacific Islands region is faced with a triple burden of disease, where an increase in the incidence of communicable and non-communicable diseases is being exacerbated by the impacts of climate change. While differing between countries, there is an overall rise in the incidence of NCDs such as obesity, diabetes, and hypertension, and a growing prominence of climate change-related health impacts such as heat-related illnesses and vector and waterborne diseases. Oh, sorry. Communities in the Melanesian subregions of Fiji, Solomon Islands, and Vanuatu have a wealth of knowledge on the effective management of local ecosystems, with many local communities relying on ecosystem services and natural resources for their livelihoods. Consequently, EBA is recognised as an effective adaptation strategy that reflects the beliefs around the intrinsic connectedness of people and ecosystems and utilises the inclusion of local, traditional, and Indigenous knowledges. In 2015 to 2020, the Pacific Ecosystem-Based Adaptation to Climate Change project was a significant regional initiative that aimed to explore the potential integration of EBA in development, climate change adaptation, and natural resource management policy and planning processes across these three countries. However, to date, there have been inadequate links between biodiversity conservation objectives and health outcomes in EBA approaches, despite this recognised link between ecosystems and human health outcomes. Additionally, a limited number of regional policies and ecosystem management services link health outcomes with biodiversity considerations in planning processes. Therefore, there is an urgent need to develop integrated EBA initiatives that focus on health outcomes using local expertise to effectively improve adaptive capacities. So the aim of our study was to conduct a policy analysis that examined the extent to which health was integrated in national climate change related policies and EBA projects in Fiji, the Solomon Islands, and Vanuatu. And our purpose was to understand the gaps around the integration of health considerations in policy content and existing EBA approaches so that we could provide recommendations on how this could be improved for future EBA projects. So our findings promote a health in all policies approach to improve local resilience and adaptive capacity for these countries. So with our study area, we chose Fiji, the Solomon Islands, and Vanuatu due to their participation in the PEBACC project and the important role of local marine and terrestrial ecosystem services in the provision of resources necessary for their economic and sociocultural livelihoods. So the most recently published national level policies, plans and strategies in English relating to ecosystem management, climate change adaptation and health were chosen, which these were sourced from relevant government ministry websites and screened for relevancy to the research aims. Peer-reviewed academic publications were also used to substantiate our analysis, which were identified through main academic databases using keywords and the process of snowballing. Our case studies were purposely chosen from the PEBACC project to demonstrate different EBA approaches in that project. So our study adopted the intersectionality-based policy analysis framework, which was proposed by Henkivsky, and this focuses on intersectionality and health equity. We used the framework's guiding principles and the 12 descriptive and transformative questions to contextualize the integration of health in EBA approaches and to then identify the key themes that we used in our policy analysis. So onto the results. Most policies included at least one health-related consideration. However, there were differences in the extent to which and the types of health-related considerations included between countries. In considering a holistic definition of health, food security was the most cited health-related impact, with all policies mentioning it at least once, and most including it in key objective or outcome indicators. But overall, it wasn't directly linked to health outcomes with the exception of two policies. Water security, sanitation, and waste disposal, however, were well addressed, and they were linked to health outcomes in half of the policies analysed. Some key policies did not include communicable diseases despite a regional increase of zoonotic and vector-borne diseases. And NCDs are mentioned across most of the policies, but often the term was not well defined and used in collective without much further detail on individual diseases where relevant. So different groups experience inequitable and disproportionate impacts of climate change, with such groups identified in the study area as women, children, LGBTQ+ community, people living with disability, the elderly, and low socioeconomic groups. Encouragingly, human rights and/or gender-based considerations were present in most of the policies. However, this was to varying degrees, and only two policies referenced LGBTQ+ groups, which reflects the heavy religious influence locally. Encouragingly, there was evidence of strong recognition around the integral role of traditional knowledge in adaptation processes. Most policies and strategies promoted the integration of traditional knowledge, such as forest management practices and traditional food production and preservation and Western scientific knowledge. Most policies didn't define the concept explicitly, but they did include information and indicators outlining how it should be considered. So EBA was explicitly mentioned in the text and/or outcome indicators for over half of the policies analysed. Definitions were consistent, but the extent to which EBA was addressed did differ, with one policy including it expressly under a strategic priority, while another only briefly referenced it under a broader adaptation-related outcome. So where it wasn't explicitly mentioned, other biodiversity and sustainable ecosystem management strategies were included, such as in the health policies. So the level of integration of the studied themes wasn't consistent across the policies. Health-related indicators where they were included often were presented separately to any environmental, gender or human rights-related or traditional knowledge indicators and analysis, with the exception of the Fijian National Climate Change Policy, which centred a woven approach and stated that all development policy must be the promotion of sustainable human well-being. Overall, this reflects the sectoral siloing present within climate change policy development, especially in the Solomon Islands and Vanuatu. Importantly, tangible linkages between health outcomes and EBA-related indicators were not present in the policies, but encouragingly, human rights and/or gender analysis and traditional knowledge considerations were more consistently integrated with EBA-related indicators. Notably, Fiji had the only publicly available national climate change and health-related policy. So within our study, we did some case studies. So I'll talk about one today, which is the PEBACC Tavanui Reforestation and Agroforestry Program, which aimed to restore local degraded forest margins, riparian and coastal systems that had occurred from forest removal and monocropping. So while the land degradation had impacted health-related ecosystem services, such as clean water provisioning, the Ministry of Health wasn't included as a key stakeholder. And additionally, there were issues with community participation, inclusive ownership, and gender inclusivity, with inclusive ownership slow on the ground due to poor coordination, communication, and overlooking of chiefly leadership. Women and youth were excluded also from the implementation phase, which generated low participation from these groups. Only basic input-output indicators were reported despite the intended use of socioeconomic performance-based indicators, which was attributed to inadequate time allocation for reporting. This study found that health-focused considerations were not comprehensively addressed in EBA projects, despite the relatively strong emphasis in national policy documents around the threat of climate change on overall well-being. Our findings uncovered some key issues, namely that the studied themes are not currently translated into formal assessments of health in the development, implementation, and monitoring stages of EBA projects. There is also limited evidence on the effectiveness of EBA projects on adaptive capacity in Fiji, the Solomon Islands, and Vanuatu, which is linked to limitations posed from a lack of baseline data, insufficient timeframes for projects, as well as a lack of consensus on appropriate monitoring methods. So based on our analysis, we provided the following recommendations. Firstly, following the health in all policies approach, a health perspective should be integrated into EBA initiatives and national policies. For EBA projects, this includes robust monitoring and evaluation frameworks with performance-based outcome and impact indicators that explicitly refer to human well-being and health. Secondly, transferable assessments such as comprehensive health impact assessments should be routinely used to facilitate cross-sectoral dialogue and systematically evaluate health impacts relating to EBA projects. Lastly, capacity building is required to assist local communities better prepare, respond, and recover from climate disasters. This should include strong gender and human rights-based considerations that engage vulnerable groups and local communities in leadership roles and participatory processes to improve project governance. So notably, the limitations of this study related to some of the unpublished policies that were currently undergoing review at the time of analysis, or policies that hadn't been updated in the last 3 years. So this impacted our access to up-to-date policy information. Additionally, we studied only publicly available government documents and EBA projects published in English, which restricted the potential amount of information available for policies and case studies. Overall, however, through this study, we have demonstrated the various gaps that exist in the comprehensive integration of health outcomes in EBA interventions across Fiji, the Solomon Islands, and Vanuatu. Importantly, further integration between health outcomes and EBA approaches are essential to inform the effectiveness of such initiatives on adaptive capacity of local communities in the Melanesian subregion. While our findings are specific to the study areas examined, our analysis could be used to better inform the development, implementation, and ongoing monitoring of EBA approaches regionally. So there's my references, and thank you for listening. If you have any questions, my email is here. Thanks.
Islam and Dr. M. Atikul Haq. We are from Bangabandhu Sheikh Mujib Medical University, Dhaka, Bangladesh. So we are talking on Climate and Health 2023. According to the World Health Organization, the single biggest health threat estimates that between 2030 and 2050, the climate change will result in an additional death of 250,000 annually. And no one is protected from the disastrous effects of climate change. It is important that people with disabilities are part of sustainable development goals. We know an estimated 16% of the global population lives with a disability, and 80% of those people with disability live in the developing countries. There is surprisingly little information available on climate change and disability. So these, with this information, our study was started with a background. People with disabilities are particularly susceptible to the adverse effects of climate change, and the relationship between climate change and the health issues faced by individuals with disabilities is a complex and interdependent process. However, the depth of research delves into the issue, especially within the framework of developing countries. So our research questions were principally, what are the documented health impacts of climate change on individuals with disabilities in developing countries? And what are the key factors influencing the vulnerability and adaptive capacity of individuals with disabilities to climate change? We have conducted a scoping review among the studies from 2005 to 2023, focusing on people with disabilities in developing countries. We have used 4 databases: PubMed, PsycInfo, Scopus, and Embase. And the 3 keyword terms were persons with disabilities, climate change, and developing countries. Mesh terms, truncation, double quotes, and similar possible terms were also employed. The included studies comprised various research types originating from approximately 10 countries and several multi-regional developing nations. And the selection criteria followed 4 phases: identification, screening, eligibility, and final exclusion of the studies. Other inclusion criteria were it must be in English, and it must be between 2005 to 2023, must be from developing countries, and there must be a relationship with physical and mental illness, coping strategies, and resilience to the natural disasters. So these were the PRISMA flow chart. A total of 463 articles were identified, with 384 from PubMed, 24 from Psych-Info, 50 from Scopus, and 5 from Embase. And finally, we have included 17 studies for our analysis. So we included cross-sectional studies, review, qualitative study, pilot study, prospective cohort study, report, scoping review, and systematic reviews. And the encompassed disability-related papers, including physical and physiological, physical and psychological disabilities, including spinal cord injury, sensory impairments, and other forms of disabilities. Our data extraction and management were included 3 independent authors, conducted the title and abstract and full text screening process. After the screening process, 4 authors extracted data independently, and subsequently the data were exported to primary documents for further analysis. Results. The comprehensive review presented here illuminates the intricate relationship between climate change, individuals with disabilities, and the impact of natural disasters in developing countries. Through an analysis of diverse studies, the review underscores the pressing need to address the unique vulnerabilities of persons with disabilities in the face of climate-related challenges. The review reveals a consensus across studies that climate change events significantly impact the physical health of individuals with disabilities. So the impact of change on physical health. There were adverse effects on spinal cord injury patients, childhood and social vulnerability, importance of information dissemination. So the extreme weather-related disasters impact individuals with spinal cord injuries due to immobility and potential dependency. There were also diverse disabilities coping with landslides. We have seen people with various disabilities in Uganda, also in Bangladesh, develop coping mechanisms to deal with environmental hazards, and emphasizing the need for diverse support systems. We have also seen global justice and inclusivity, ethical issues related to disability inclusiveness in the face of climate change, highlight the necessity for global justice and inclusive policies. And impact on climate change, impact of climate change on mental health of people with disabilities. So there were heightened vulnerability for people with disability, and individuals with disabilities are particularly vulnerable to the mental health impacts of climate change due to, number one, increased stress, 2, anxiety, and trauma during extreme weather events. And the direct impacts of mental health were intensified stress, anxiety, and other stress disorders. And there were some indirect impacts, including mental health through shifts in the environment. The impact of climate change on mental health is continued here. So there were limited research on these issues, and the urgency for support is required for limited resources, preparedness, and disruption in healthcare and support services intensify vulnerability, emphasizing the urgency for tailored mental health support for individuals with disabilities in the face of climate change challenges. So the coping strategies for individuals with disabilities. There should be specialized care for cognitive disabilities. There need to be vulnerability of children with autism spectrum disorders. So what we have seen, the cognitive disabilities, individuals with cognitive disabilities need extra care during disasters due to limited risk awareness. Research gap exists here in understanding the disaster perception among those with cognitive disabilities. And vulnerability of children with autism spectrum disorders, as children, especially those in low-income families, face higher rates of anxiety and maltreatment during the disasters. And coping strategies for individuals with disabilities, and the government initiatives and communication tools, local coping strategies, cluster approach for effective coping. So all these three things we have seen. Some governments, like India, they have initiated rescue teams using sign languages and communication tools for individuals with disabilities. However, full implementation was pending. And also in Tuvalu, coping strategies include staying alive, local alert system, and religious practices. And the cluster approach for effective coping was collaborative involving local communities, government agencies, and NGOs, known as the cluster approach, have effectively in rescuing individuals with disabilities during natural disasters. The resilience strategies for individuals with disabilities, there were telemedicine for spinal cord injuries, there were community recovery, there were social isolation and discrimination. We have seen telemedicine implemented globally, especially this is after COVID-19, provides prompt responses and immediate care for individuals with spinal cord injuries during disasters. That is to prove to be sustainable approach, enhancing their resilience. And other resilience strategies were community programs and training, assistive devices and infrastructure, building back better. Here I can mention assistive devices and infrastructure, implementing assistive devices such as hearing aids, wheelchair, and visual aids, coupled with resilience housing infrastructure, strengthens the resilience to persons with disabilities. These measures have seen effective approach against natural hazards. And of course, building back better approach was also emphasized in various other studies. So in conclusion, this comprehensive review underscores the urgency of addressing the intersection of climate change, disability, and natural disasters in developing countries. It highlights the dual impact of climate change on physical and mental health, urges the development of tailored coping strategies and resilience mechanisms, and also emphasizes the need for inclusive mental health services. The review also draws attention to gaps in research and the importance of intersectional approaches that consider the unique experience of individuals with diverse disabilities. I am done. Thank you very much. You can stop share.
These guys can see me.
There you go.
Perfect. Thank you. Thanks to all of our wonderful presenters. So now we can take some questions for everybody except for Taslim, who's not online. But Jacky is still online, I believe. And then we have Melissa and Jacky here. So questions up the back.
First, I just say all these presentations are really outstanding. And my first question on this one is for Ms. Blum. Could you please say how exposure was defined and why you did not include spontaneous abortions?
Yeah, both really good questions. I think the question of how to define heat exposure is actually
a complicated one in the field because many studies use different approaches. And so what we did in this study was very simple, season-based approach. So whenever summer fell during your pregnancy, you said you were exposed to heat during those months of June, July, and August. But many studies have used meteorological approaches. And what you actually see if you read the literature is there's not always agreement between studies that use average temperature over a period of time, or ones that look at a heat wave that lasted, for 2 days with a very hot temperature on those 2 days. So I think it's an open question of the best way to assess exposure, and maybe we need to be doing it in all of those ways so that we can warn people at the appropriate time. And sorry, could you remind me the second half of your question?
Why you didn't look at it?
Yeah, in this study, we did not look at spontaneous abortion because I think the rate was pretty low in the data that was available, so we didn't have sufficient power.
Okay, another question? Yes.
My question is to Melissa again. I wanted to know whether you have looked at the adaptation behaviors or adaptive capacity of the individual women child payer. That is the first question. And the second question was, what do you think, what could be the role of physiological adaptation in mother and the health impact that you looked at?
Yeah, both great questions. We did not look at adaptive behavior in the study because the data was collected 2009 to 2014, so we can't go back and see what people were doing at that time, but I think it's a really important question because it does affect whether someone was exposed, right? Whether they saw, oh, it's going to be hot today, I should turn on the air conditioning, or I should go to the library so that I can have air conditioning in my environment. And then the second part about adaptation, physiologic adaptation to heat, also an interesting one. Studies have definitely shown that acclimatization can occur. So if you're consistently exposed to hot temperatures in your environment and then you have a day that's 95 degrees, maybe that's okay because you have better tolerance. But I don't think those mechanisms are very well understood. So definitely an important area for future research as well.
Brilliant, thank you. And we've got a question online again. In the study of heat exposure during pregnancy, did you ask pregnant patients how much time they spent outside during those months, or look at average temperatures those months to more specifically identify the level of heat exposure that increases the risk of complications?
Good question. Again, we were not able to ask people how much time they spent outside. I think it's really important piece of information to have. And then in terms of using meteorological data, we are planning to do that in a future study. We're collaborating with a group that has very granular ambient temperature estimates that use green space and satellite data to really estimate, like at the level of a city block, what was the temperature where this person was living. And that's really how we want to approach it because we want to get the best estimate of what heat this person actually experienced. So future work.
Great, Iris.
Thanks so much. Short follow up on that one. You have Dr. Bernal on one of your slides, I think. She did some really interesting research in the Gambia where she did direct measurements of women, pregnant women, working outside of the temperature, and they wore those devices themselves. Do you think that could be an interesting next step as well, for example, in the US? And then I'm wondering, what do you think solutions could be to this issue?
Yeah, I think that's a great idea for a future study, certainly. I think the cohort is not currently enrolling new patients, but for a future cohort study, absolutely. And then in terms of solving the problem, I think different groups have proposed strategies. One is sort of an early heat warning system. So if you're running like a primary care practice, for example, send a text message to all of your patients saying, today's gonna be really hot, you should stay inside. Or here's a city-funded cooling space that you can go to. New York City also has a program that's supposed to subsidize air conditioning for low-income people living in the city, but it's chronically underfunded, so more money for that.
Yes, Tina.
Yeah, thanks. This is a question for Mr. Alexander. The question I have for you is, this is really cool. I mean, are you thinking that in the future, there'll be like an AI application that will allow what clinicians, public health people, who's going to actually use this? And in your view of the future, how is it actually going to work? Like, what would actually happen practically using this kind of tool?
Great, thanks so much for your question. Okay, so the tool that I specified, I think, was directly most geared towards weather forecasters. These people are doing things that impact public health in the sense that they are the ones who issue alerts, watches, and warnings, which tell people to shelter in place, etc. So there is definitely a direct public health application towards including these vulnerability aspects of the community into a weather forecast, and saying not only are we going to have, say, an EF3 tornado or magnitude 2 hurricane, but also saying that it's going to affect this area, and therefore we should take it more seriously, and that particular community especially should be notified. And we know these characteristics about this community, like there is the area of the city which has a lot of people who are limited English speakers, or who don't have access to an emergency response system, so we should target these especially, and this could all be available in the system for these people who are weather forecasted. The goal, I think, also in my head is that these are web-based tools that anyone could use and see the forecast for themselves and make these own judgments. So it doesn't just happen in a weather forecast office, but it happens. So any one of us, if we're experiencing storm, if you know people that are going to be affected, these are areas where even politicians or other emergency response groups could go out and target these areas specifically on their own and provide support and planning in advance. But I think the issue of climate and weather is complicated. A lot of us in this room think climate long term, but it manifests in these short term events, which we forecast out a certain range out, and that's our warning for actually responding. That's the amount of time that we have to respond. The amount of information that we can provide, we can increase the information that our forecast we can provide people with more time to respond and prepare for these events.
Thank you. Next question, James.
Thanks. I just wanted to share some examples from the Caribbean of managing people who have disabilities and chronic health conditions beforehand. So some of the islands get hit with hurricanes with such regularity that the messaging now is definitely around getting all your medicines into a bag and strap them to your body. You have to go from your house to the shelters so they don't blow away. You may be familiar with work in Puerto Rico that Hurricane Maria, the official death toll was 64, but about 200 times more people than that were documented excess deaths in the months that followed, and mostly people with diabetes, heart disease, other disabilities. I saw a really good model in Tobago, which is like a small district health department of 50,000 people, visiting there last year. So they have a system where there's a form in the community center and in the health center that you or your family can fill in to indicate you have insulin-dependent diabetes, or you have a disability, or what have you. And then in the event of a disaster, which are frequent with heavy rain and floods and landslides, they know in advance. That is confidential database shared between the Tobago Emergency Management Agency and the health department. So they know in advance who will need medevac, who's going to need insulin, and that seems to be a promising system. And I've been pushing them to write it up because that looks like a nice practice. My dream is that we'll have cloud-based medical records for continuity of care. Because if you have to leave in a hurry, you may lose everything, and then you have to migrate to the next island for a few months or a year or two. You really would be beneficial to have cloud-based records. Thank you.
Thank you. And I think that's such a key point. In Australia, we have the same problem. Even between our cities, we don't have cloud-based records that allow people who are displaced to be able to access continuity of care. So, Mark-Lee.
I have a question for Jagger in terms of this. Is there an international counterpart to what you did in the US? And if so, that would be really interesting to have people work on that. And then my second question would be, what would be the role to get weather forecasters and health professionals together? Because it seems like we should have a separate meeting where we invite, these 120 people and the people interested in climate and health and work on solutions.
Yeah, okay, so 2 questions. So I'll start with the first one. So the international correlate to essentially the software, which is CONUS, comes from the United States and US territories. So the software that NOAA funds is unfortunately over the US. The data that they collect from these 120 WFOs is the US and US territories. So also Guam and Puerto Rico, that data for. The weather model data itself is produced over the entire globe. So some of the actual forecasts are over the globe, but the health data is marginally, so each country and each health system is collecting data on their own instances, and that can be a real challenge in the international realm. But a similar system could theoretically, it could be a framework for other countries to implement their own system, which is a good starting point. And the second question, sorry.
Bringing together health professionals and weather people.
Right. So a lot of that, I think one of the most important areas that I see that is actually logging the health effects of these natural hazards as they occur. With something like a high wind event, it's really easy for them to log direct or indirect effects of a high wind event. Say a tree falls over and it causes a car accident, and so then that's logged as a tree falls over from a windstorm and causes a car accident. So that's logged as a injury in the NOAA storm events database, and is correlated with that hazard in the past, correlated with that hazard child magnitude and other information associated with it. But then it's a lot more complicated for them to reach out to the county, which has information from various health systems, which has actual related injuries and diagnoses, which is why it's so difficult to get information on heat. They do have some of that, but a lot of the time it's not coded or logged properly by the health system and doesn't end up in their events database properly. So long term, I think that is something that's really important, that we can correlate diagnoses with some of these actual events that have occurred, and that's one step that's getting a lot better data on what hazards are actually causing what in the health system. But again, that's going to take serious overall, I think, some serious progress.
So it would be cool if we did get together with them.
With someone.
Okay, we've got time for one more quick one. Quick question, not a question, comment. Yes.
So in climate modeling, a lot of climate modeling uses historic data. It doesn't do current climate informed data, including things like water vapor, sea level rise, all these other things. There are big groups that do this, like Argonne National Labs and places like that, where they do this hyper local climate modeling. So I'm wondering, how if you gathered the data that you got from the vulnerability perspective and laid that over with the climate modeling, how some more sophisticated climate modeling might help in a predictive way?
Right. So these are weather forecast models, which are essentially the same thing as global climate models. They're on a higher resolution. So climate models might be on the order of 50 kilometers by 50 kilometers grid spacing, or some other like hexagonal grid or something more complicated. But these weather forecasts are on the order of like 1.5 by 1.5 kilometers, and they're allowed to do that computationally because they're going about 14 days out, for a climate model and going years out in the future. So for the climate models, they have to use these coarser grids. For the weather models, we can use these finer grids. So they actually do have lifetime updates of a lot of those climate system variables. Like you said, with data being assimilated from different satellite and station-based measurements, which are doing these forecasts. And forecasts are getting better and better. Like I said, these are on top of the forecasts. We have a bunch of different models. We know that all of the models have their own problems, but we have to say 10 or 20 models running at once, and you get a distribution of the range of forecasts, which is how we can say, oh, there are all these possible storm tracks that it might take, because we have these different initial conditions and different model parameters. So that's where the ensemble comes from. But if you have any questions about how these models work specifically and how we can optimize them for this, I'll be happy to answer those and go more depth.
Brilliant. Thank you very much. All right, we will close up our session. I'd like to say a big thank you to Melissa and Jagger in person, Jacky online, and Taslim in Bangladesh. So round of applause, fantastic. Thank you so much.